Yes, when you can start now.
Good evening, everyone, and good morning in the US. We are thrilled today as we present to you the next webinar of AARO, which is the All India Association for Advancing Research in Obesity. As you all know, we are going global this year with the AOCO being hosted by AARO this year in December 2025 in New Delhi. And this series of webinars are just a prelude to the same. Without much ado, may I invite our General Secretariat, Dr. Brij Makkar sir, to give us some opening remarks as well as introduce our first speaker for the day.
Thank you, Dr. Purvi, and good evening, everyone from New Delhi. It is indeed a great pleasure to be on this webinar, and it's a great honor to have with us Professor Donna Ryan and Professor Nitin Kapoor, two very accomplished personalities in the field of obesity. As Purvi just mentioned, this year we are going to have the AOCO 2025 in New Delhi on 19th to 21st of December. Uh, I'm sure you all know AOCO is the Asia Oceania Congress of Obesity, and this is happening in India after 2010. Last we had was 2010, and this year we are having again. And the details are already on the website. Anybody who wants to look up more details and join, please visit our website, which is aiaro.com. We have two speakers and we have a pretty tight schedule. Professor Donna has to leave after her talk, so I'll not take much time. It's indeed an honor to introduce Professor Donna Ryan, though she doesn't need any introduction in the obesity circles. She is one of the pioneers in the field of obesity, Professor Emerita from Pennington Biomedical Research Center. I'm not sure how many people know about this research center, but I have personally visited this center, and this is a pioneer center in obesity research. She is one of the ace researchers globally and is also one of the past presidents of World Obesity Federation, which used to be erstwhile, IASO, if I'm correct.
Yeah.
So she's going to speak on more tears are shed over answered prayers. That's the topic, which is extremely interesting. So over to Don.
Yeah. Thank you. Thank you so much, Dr. Makar. And thank you, Dr. Purvi Chawla, for inviting me to be here. I am delighted to talk to the people of India about this. You know, you're going to have semaglutide coming on as a generic, and everybody in India is going to be interested in what I have to say. So, yeah, our prayers were answered, but there's a little more to it to that, and I'm going to explain this title to you, More Tears Are Shed Over Answered Prayers. So these are my disclosures, and you need to know I consult with all of these companies that are trying to make these drugs and some devices and some lifestyle companies that are trying commercial lifestyle companies. So I have lots of industry contacts, and you need to be aware of that. I have a bias. I believe in the biologic basis of obesity. I think we need medicines to help our patients achieve weight loss and achieve all of the health benefits that this chronic disease burden is putting upon our patients. Okay, so let's begin with answered prayers. You know, we prayed long and hard for obesity medications that could produce the weight loss that we saw with bariatric surgery. And guess what? Those prayers have been answered. We are in the golden age of obesity medications. So what I'm going to talk to you about is how these medications produce robust weight loss, how they have other properties, not just mediated through weight loss, but they also have disease modifying properties, many times independent beyond what you get with the weight loss itself. But look, there's still some challenges that remain. And so my third objective is have you walk away with some knowledge about the challenges and how we need to address them. So this shows you the development of obesity medications up until we got to the modern era. And everything in gray are failures. The ones in blue are the ones that are still on the market. So yeah, we still have phentermine around since the 1950s, and we also have orlistat. But look, this was not a very productive place, and it was a lot of hard work. And this is what I felt like down in the slave galley working hard to find medications to help patients. We were not successful. It was very difficult for a long, long time. But then semaglutide and tirzepatide were developed, and they produced enormous interest. First of all, because of the amount of weight loss that they were producing. So, there's a lot of variation. Individuals will vary in the amount of weight they'll lose with any treatment. That's just the variation in weight loss response. But with these medicines, we were seeing with semaglutide 15 to 17% weight loss. With tirzepatide, 20 to 22% weight loss on average. Some people were losing more, some people were losing less, but this average weight loss was something that was really remarkable. And it produced a lot of interest in the public in these medications. So I'm showing you here the average weight loss with our older medications, the combination phentermine topiramate, the combination naltrexone bupropion, and liraglutide, the first GLP-1 to be approved for weight loss. Look, they're about 5 percentage points greater than placebo. The placebos are shown here in blue in all of these different studies. These are not head-to-head comparisons. But when you get to semaglutide and tirzepatide, you see the weight loss in orange really jumping up. And that was what really prompted an enormous amount of public attention. So this shows how we did that. Native GLP-1, we've known about this since the 1980s. And this is a hormone produced by the L cells in the distal intestine. And it has a half-life of about 1 to 2 minutes because it's rapidly metabolized by DPP-4. So we developed this group of medications, the DPP-4 inhibitors, to make this incretin effect from this hormone longer acting. But we also exploited GLP-1, and we developed these biologics. The first one was liraglutide. That's the picture of its amino acids there. It has 97% homology to native GLP-1, but it's been sort of crafted to be longer acting. It has a fatty acid side chain, so it has a half-life of 13 hours. We dose liraglutide daily. But the real step forward was semaglutide. It still has 94% homology to native GLP-1. What that means is no off-target effects. We know what the biology is going to do of this medication, but look how long-acting it is. It has a half-life of 5 to 7 days, 165 hours. That means we dose this weekly. Yeah, that's a big thing. And then in all of medicine, if we get one benefit from hitting one target, we'll add another target and we'll get more benefits. So that's true how we manage blood pressure. We add medications that hit different targets. Well, this is tirzepatide was engineered to target 2 receptors, GLP-1 and GIP. These are both naturally occurring incretin hormones, but they both have an effect on appetite and produce weight loss, also glycemic improvement. So tirzepatide and semaglutide are developed for both diabetes and for weight management. But what's important about these medications is not just that average weight loss, it's that most patients are going to have a good response. And so here I'm showing you the top dose of tirzepatide in blue on the top, and then placebo on the bottom. And these are waterfall plots. So what this is every individual's weight change is shown as a bar here. And I've shifted that placebo graph over to the left to a line where people start losing weight. Everything to the right of that is weight loss. Everything to the left of that is weight gain. And as you can see, 97.7% of individuals on tirzepatide lost weight compared to only 67% of placebo. But look at the 5% weight loss. This is when we start to see health benefit. 96.3% achieved 5% weight loss or more, and 90% achieved 10% weight loss or more. What this means is that nearly every patient we prescribe these drugs to is going to have clinically significant weight loss. That's a big deal. The same thing is true for semaglutide. They make us work for this. They don't show us the intuitive waterfall plots. No, we have this cumulative distribution. But what I've done here is I've drawn the 5% hurdle on is a green dotted line, and the 10% is orange. And everything to the left of that is people who lost more than that. So with semaglutide, 92% loss, 5% weight loss or more, 75%, 10% or more. Much, much better than placebo. And most patients are getting clinically significant weight loss because at 5 to 10% weight loss, we get a lot of health benefits. But even more important than weight loss is that we are seeing disease-modifying properties with these agents. And I'm going to talk to you about that. And it's important that we recognize this because, look, the social media loves to make a big deal about weight loss, but these drugs are a lot more than weight loss. These are chronic disease medications. This is what is going to change everything. It's not the weight loss. No, it's the ability to modify all of the chronic diseases. And as you know, these are our main public health challenges in the 21st century. So we know a lot, we're learning a lot more about how these naturally occurring hormones work. And so there's a lot more to the effect of GLP-1 than just its effect on appetite and its effect on the incretin effect on glycemia. No, it also has effects. It reduces blood pressure independent of weight loss. It promotes natriuresis and diuresis in the kidney, cardioprotective. It makes platelets less sticky. It delays gastric emptying. It produces changes in postprandial lipids. And more important, we're learning it has anti-inflammatory effects. Yeah, and furthermore, now we know that this GLP-1 is not just produced in the gut, it's produced in the brain. Yeah, and it's doing things in the brain that have a very important effects on glycemia, on appetite, on inflammation, and on the immune system. So this emerging knowledge about how GLP-1 is working in the brain to affect inflammation in the immune system is really driving a lot of attention to these GLP-1 based medications. The big change in the game was this SELECT study. I was co-chair of the steering committee of this, and I'm telling you, this was the happiest moment of my life when we showed that in people without diabetes who just had obesity and prior cardiovascular disease, they're at very high risk for their second heart attack, their second stroke, their sudden death from cardiovascular disease. We could reduce that by about 20% with semaglutide. So this shows the cardiovascular outcome trials primary endpoint. In purple, we have semaglutide. In green, we have placebo. And you can see these curves start separating immediately. We're getting an immediate effect of this drug before we get substantial weight loss, even before we get a full dose escalation. So we've done subsequent studies on this that suggest that the effects of semaglutide are mediated in part through weight loss, but predominantly from other factors we don't fully understand yet. So this is me, I'm right in the middle, and this is the day we revealed the SELECT results. And let me tell you, this changed the game in the United States because for the very first time, our government insurance, Medicare, said they're going to pay for semaglutide, a medication for obesity. If you've had a heart attack or a stroke, or if you have symptomatic peripheral artery disease, you can get Medicare to pay for this medication. That's a first, and that is the beginning of the big game change in the United States. So since then, the SELECT trial it's really been a huge source of knowledge about how semaglutide, how this compound with 94% homology to native GLP-1 produces many effects. It reduces weight, of course. It also has effects on preventing the progression of kidney disease. We also showed it has effects on preventing glycemia and progression to type 2 diabetes for people who have prediabetes. We looked at its effect on inflammation. We're looking at the mediation effects. Very important, a reduction in all-cause mortality, a reduction in COVID deaths. Yeah, isn't that fantastic? Yeah. So all of these benefits of the medication, and we believe they are beyond just mediation through weight loss. So yeah, it's been studied in HFpEF. Semaglutide has been studied in HFpEF, and it shows not just patients feel better and can walk further, they also have reduced hospitalizations. That's good. Chronic kidney disease, prevention of the progression of chronic kidney disease. There's a 22% reduction in the composite kidney endpoint in SELECT, and a 24% risk reduction in FLOW. And when we look at mortality and COVID-related deaths, yeah, we showed there was a dramatic reduction in COVID deaths in the patients who were on semaglutide during SELECT and during that COVID pandemic. Tirzepatide has an indication for obstructive sleep apnea. Yeah, it has a dramatic reduction in apnea-hypopnea index. And so now people are getting their tirzepatide paid for by their insurance because if they can demonstrate they have a sleep study that shows an AHI 15 or greater, they can get this medication paid for. And they have about a 50% chance of being able to get off of their CPAP, losing weight, reducing the pressure around the upper airway, and being able to get off of their CPAP. So we're seeing all of these label indications. Yeah, we have many GLP-1s indicated for diabetes. We also have 3 that are indicated for obesity. We have a new label indication for semaglutide and cardiovascular risk reduction. We have a new label indication for semaglutide and osteoarthritis. Tirzepatide is indicated for treatment of obstructive sleep apnea, and semaglutide has just been indicated for MASH. Yeah, but look, there are a lot of other chronic diseases where we have emerging evidence and ongoing studies where we're looking at chronic kidney disease, psoriasis, neuroinflammation, Parkinson's disease, infectious diseases like COVID, asthma, and many other heart failure, other indications. This is a very active area of discovery. And this is the thing that you need to know about these medications. They are much more than diabetes or weight loss medications. These are chronic disease medications. And these 2 agents that we now have available are just the beginning. There's lots more coming online. So we're targeting these nutrient-stimulated hormones, not just GLP-1 and GIP, but also glucagon and amylin and PYY. Yeah. And so we have drugs in development that are dual agonists, that are triple agonists, that are targeting. Most of the time we use that GLP-1 as kind of a backbone, not a chemical backbone, but sort of a metaphorical backbone, because we know that GLP-1 has all these positive benefits. So we're using that as the backbone, and then we're adding these other targets to sort of improve the profile. Glucagon, because glucagon has receptors in the liver, and we think it may be especially efficacious in MASH, and like that. Okay, so that's something very important for you to watch. So we're also coming up with oral agents, even longer acting agents, 8 drugs we can be given monthly, medications we can be given by mouth, not peptides, small molecules, easier to produce and distribute. So that's coming too. But along with that, we have a lot of interest in preserving muscle mass and preserving fat mass. Preserving muscle mass and preserving bone mass. You're going to have another lecture related to that today. But anyway, so there's a big interest in developing biologics that can help do those things. So what we're seeing here is it took us a long time. We have the Sisyphus effect. Sisyphus was the Greek god who had to roll the rock up the mountain every day, and then it rolled back down. He had to start over the next day and roll it back up continuously. So he had the long, hard struggle to get to the top Now we have the snowball effect. There is so much happening all the time, it's hard to keep up with it. It's like drinking from a fire hose. And one of my favorite sayings is from Saint Teresa of Avila, and she's famous for saying, more tears are shed over answered prayers. So yeah, we prayed long and hard to get these medications, but things aren't perfect. We are shedding some tears about these wonderful medications, and I'm going to talk to you about what that is. Well, first of all, not everybody can take these medications. We do not give them to people who have a history of multiple endocrine neoplasia type 2 or a personal and family history of medullary thyroid cancer. In animals, in rodents, these GLP-1s can promote thyroid C-cell tumors. So we're very careful in humans. If you have a family history of this, we're not giving you this drug. Some people are allergic to these peptides or to the things that are in their solution, the excipients that they're using. We don't give them during pregnancy. There's a warning about pancreatitis. It's rare. It's like 1 per 1,000 in our clinical trials, but we still need to be aware of that. Some people cannot take this drug because they will develop drug-associated pancreatitis. Fortunately, very rarely. When you lose a lot of weight, you have increased risk of gallbladder disease, and we need to know about that, and we need to be able to manage that. The medications cause nausea and vomiting, and if it's severe, patients can get dehydrated and get acute tubular necrosis, renal failure. We've got to really watch out for that. And with all of our weight loss medications, we have a suicidality warning, because when you lose a lot of weight, it can be emotionally stressful. So we need to be careful about that. Gallbladder disease, very important. If your patients have symptoms of nausea, vomiting, abdominal pain, well, we're going to work them up, and we may have to remove their gallbladder, but then they can go back on the medication. Now, remember that psychiatric thing, because some patients, when they lose weight, it does not solve all their problems, right? And sometimes it causes relationship problems. And so we need to recognize that with a lot of weight loss, there's an increased risk of self-harm or suicide. And we need to be alert to this. And if our patients experience this, we need to get them to a good psychiatrist. We need to stop the medication. It is possible to lose weight too rapidly and to lose too much weight loss. These medications can have powerful effects on appetite. The patients can just stop eating and stop drinking. Not good. And when you're in that negative energy balance and you deplete all your glycogen, you can get ketosis. That further suppresses your appetite. So we need to be very careful about this and really watch the dosing. Do not increase the dose too rapidly. Make sure patients that they're not getting into trouble with that first dose of medication. We also need to recognize that with that rapid weight loss, we can sometimes get in trouble with medications that we're on. You may not need the diuretic because you're having a natural diuresis by depleting your glycogen and the water that's associated with glycogen. And you may not need your blood pressure medicine because you're also reducing your blood volume. And so you may not need your glycemia medications, because if you don't have any carbohydrate intake, you don't need all that insulin. So for gosh sake, stop the sulfonylureas for patients who are on these medications. The other thing is that people who are smaller, and I want all of the people in India to listen to this, they are at increased risk of going too low. So this just shows you. I looked at the step 1 and the SURMOUNT studies, and this is a semaglutide in blue, tirzepatide in orange, and retatrutide, the next one that's coming, in green. And this shows you that the patients who are able to lose 5%, 10%, 15%, 20%, 25%, 30%. With this new drug, retatrutide, a fourth of patients can lose 25%. That's a lot of weight loss, right? Well, if you start with a lower BMI, you can get in trouble. So look at this. Look at that BMI of 27. And I've drawn the green line, that's below a BMI of 25. The orange is below a BMI of 22. If you lose 30% weight loss, and your BMI starts at 27, you're now down to 19. If you lose 40%, you're 16, your BMI is 16. That is too low. So individuals like India, people in India, if you're starting with a lower BMI, you need to be very careful about too much weight loss. So people who have started a lower BMI, they're at greater risk. Older individuals, because they start with a lower lean mass. You know, as you age, you start losing lean mass really at age 30, but by age 60 and beyond, it really accelerates. And women, because of osteoporosis that occurs post-menopause. And also, I think there's a huge cultural drive for slimness among women, and they have realistic expectations about what they want their body size to be. So you've got to be careful of that. So here's the problem. This shows you from the Look Ahead study, a lifestyle intervention, the people on the control are in red, the people in the lifestyle intervention are in blue. Look on the left, we see there's weight loss almost 9% in the first year. We tried to keep them down, but they are slowly regaining. And then look at what happens about halfway into the study. Both groups start losing weight. Well, you're 59 at the start. 10 years later, you're 69. And as I told you, in your 60s, you start accelerating that lean loss. And we actually see on the population weight loss that begins in your 60s and 70s. And so what's going on there is they're losing lean mass, both groups. And we know that they're not losing fat mass because look on the right. There's the waist circumference. It's stable, but the weight's going down. They're keeping their fat, they're keeping their visceral adiposity, but they're losing lean mass. And this has implications for falls. So here are the frailty fractures. This is a frailty fracture is a fracture that occurs from a standing height. And as you can see, the lifestyle intervention is in blue this time. Significantly higher rates of frailty fractures. Yeah, and in the SELECT study with semaglutide, there were numerically higher rates in women and in patients over age 75 of fractures of the hip and pelvis. We need to be careful about this with weight loss. So I'm going to skip this because of time, and I'm going to say what we're really trying to do is make our weight loss better. Don't be thinking about more. Think about better weight loss. So we've got some challenges to be confronted, and the way to do that is with a skilled workforce. And I believe that we can develop that. We need to make sure that we have access to these medications because they can be life-saving. They can really improve the lot of our patients. But to do that, we have some challenges to meet. We need a skilled and educated workforce. We need to make these medications affordable. These should not be luxury products. And we really need to keep doing research. We need to know what's the best way to decide who should be getting these medications and what's the best target for weight loss. How much weight loss should we be losing? How should we be following that? So I want to thank you so much for giving me this time to talk to you. I enjoyed it immensely.
Thank you, Dr. Donna, for a wonderful, very, very crisp, still very exhaustive presentation. I think I can't imagine the amount of things you covered in short span of 25 times and
That's
gave
right.
such a wonderful overview of how things are changing in management of obesity. If we have a couple of quick questions, Purvi, can you check on the chat box? We can toss it to Dr.
Yeah,
Donna
let's see.
just now.
So
You
we don't
know, the
have
question I
any
always
questions.
get is, how long should we take these medicine? Right? That's
Yeah,
what everybody
that's
wants to
one.
know. Yeah,
Yes.
that's the number one question. Look, if you're taking this medicine to prevent a heart attack, to prevent a stroke, why would you stop? We know it's more than just the weight loss. It's the medication itself seems to be having benefits. But for younger people who don't have complications, maybe we can develop a strategy to help them stop. So this would be people, 20, 30, 40 years old who don't have obesity complications. If we could reduce them and keep the weight off, there may not be a reason for them to continue the medication. So we really need to do a lot of research to find out effective ways to stop.
Donna, there is one more concern which is there, and that is sarcopenia, which is being discussed left and right everywhere, and we don't have the right answer to it. And even, we had the trial going on with bimagrumab. Bimagrumab trial has been put on hold along with tirzepatide because of, the liver function and dyslipidemia concern. So, what is your
Yes,
take on sarcopenia as one of the concerns when we are, going for weight management?
we have got to address sarcopenia, especially if we're going to use these medications in an older population, right? Because that's the group that's at risk because they're already developing sarcopenia because of the endocrine involution of aging. So yeah, we've got to address this. The problem with bimagrumab is that yeah, it has great effects on reducing body fat and preserving body body lean mass and muscle. But look, in that belief study, it showed that something was happening with all that fat that was being mobilized. It caused a dramatic increase in LDL, about 30% at the first month. And there were liver enzyme increases. So all that fat was going to the liver to be processed. That's a problem. We must solve that problem for bimagrumab. But at EASD, there was a paper on another one of these activin myostatin inhibitors. I think it was trevogrumab by Regeneron, and it did not have that LDL problem. It did not have the liver enzyme problem. So hopefully we'll be able to eliminate those problems and still be able to find an approach to preserve muscle mass. Good
And
question.
your comments about you said, we need the scalable drugs, the, small molecules to treat obesity, and we have already data from orforglipron. What is your
Right.
take on this? Because we had danuglipron also, which was called off because of
Yeah.
the hepatotoxicity.
One thing about these biologics that's good is they're metabolized like proteins, right? So they don't really cause any problems. But when you get the small molecules, they go to the liver and these enzymes break them down, because they're not peptides. And so you always run the risk of running into these rare liver problems. Look, that happened with the TZDs. It happened with rosiglitazone. Yeah. And it happened with danuglipron. It's the liver problems from the small molecule. So orforglipron looks pretty clean in patients with obesity and in patients with diabetes. But that's from data on about what, 5 or 6 thousand individuals. We need to be careful when it goes out into general use and it's used by millions of people. We may pick up signals because these are
Yes.
rare events, and so we need to be watching that very carefully because the metabolism of those small molecules is different. We know one of the beauties about these biologics is, oh my God, it's a miracle. They're all on target. Yeah.
Yes. So one more
So I'm
thing
very
that is
excited
come.
about India going generic. Yay.
Yes, we are also excited. So one
Yes,
more
we
quick
have a
question is,
massive market created with the AOMs.
yeah.
Good.
So one more question is, with these molecules and the hype that has been created by social media around these molecules, like these are like magic bullets that you take and everything is taken care. And it seems that people are thinking that, you have something which can help you lose weight without any physical activity or exercise. And that's where, again, sarcopenia is, one of the challenges. So what is your take on that?
That is why my title was More Tears Are Shed Over Answered Prayers. Okay, you got a drug, it's wonderful, it has a big effect on appetite, but you're achieving these benefits without the benefits of fitness, without the benefits of a higher quality diet. Independently, fitness has an effect on your health, and so does a higher quality diet. We need to incorporate those things into this treatment. Unfortunately, people are just they're taking this medicine and are not working on improving their diet quality and improving their fitness.
Second question is, we have just one question in chat, Dr. Parul here, that what is the role of nutritional supplements in people who are on these, anti-obesity, or you can say obesity modifying mm, medications?
We know this very well from bariatric surgery. When you have bariatric surgery, you are given supplements. You see the nutritionist. You see somebody about an exercise physiologist who gives you a prescription for how to exercise. We're not doing this. We need to follow our brothers and sisters in bariatric surgery. We need to wrap around these patients. If you can lose as much weight as bariatric surgery, you need to be taking supplements. You need to be making sure that you're not in those early days when you're in negative energy balance, you need to have enough protein, you need to have enough vitamins and minerals, and we need to be doing that. And we're not there yet, and we need to get there.
So, another question is, people think that if they're taking supplements, there is no need to exercise. Do you agree to that?
No, I don't agree to that. Of course not. Look, I just told you this. So listen to me. One of the predictors of longevity, one of the predictors of health is fitness. Yeah, you've got to do your exercise to improve your fitness. Come on, y'all.
Yes, I
There
think
is
that,
no
these
pill
are
you cannot take a
the
pill and get fit. No.
so there is no shortcut to health if we are not exercising regularly.
And look, the India has led the way. You've led the way in how to have a healthy life. It's about yoga, it's about breathing, it's about movement. It's about diet. You have the best information in the world. Why don't you get on this? Help us over here in the West.
I totally agree with you. I just brought up these provocative questions because, day in, day out, people are thinking that these magic bullets are going to take care of, exercise. And I'm sure the day we get a pill which can substitute exercise, somebody will get a Nobel Prize.
I do not know what the Indian metaphor is, but the metaphor of more tears are shed over answered prayers is a really good one.
Yes, I agree.
Okay, thank you so much for having me.
So thank you so much for taking out your time and joining us for this wonderful webinar. It's always wonderful, connecting with you.
Oh,
Thank you so
yeah,
much.
great to see
And
you.
we'll move on to the uh, next session with Nitin. And Donna, certainly hope to see you sooner than later. We'll
I
try
hope
to get
so.
you to India soon.
Thank you,
Bye bye.
Dr. Donna. Fantastic.
Bye, Purvi.
Thank you. So for the next talk, we have Dr. Nitin Kapoor with us. I would hand over to Dr. Purvi to introduce Nitin and do the second talk.
Thank you, sir. It's my great pleasure to have and to get this opportunity to introduce Dr. Nitin Kapoor. He is a senior endocrinologist, professor, and head of unit Department of Endocrinology, Diabetes and Metabolism at CMC Vellore, India. And he completed his DM and postdoctoral fellowship in endocrinology at CMC Vellore, and then his PhD research on clinical and genetic indicators of obesity from the University of Melbourne, Australia. He's been cited as among the top 2% of the most influential researchers across the world by Stanford University, USA, in October 23 and September 24, has received several awards, prestigious ones that too. And recently, he also was awarded the President's Award of Appreciation by the Endocrine Society of India in 2022 and the Best Mentor Award of the year 23-24 by the director at CMC Vellore. He's the editor of the current and the previous two editions of the book, A Practical Guide to Diabetes Mellitus, and also the section editor of the obesity section of textbook of Endotext, the PubMed indexed endocrine textbook. Without much ado, let's present Dr. Nitin Kapoor.
Thank you so much, Dr. Purve, for that very, very kind introduction. And it was absolutely a pleasure to listen to Dr. Donna Ryan and hard to follow such a renowned speaker with the talk. Nevertheless, I think my topic is more relevant in terms of the Indian phenotype of obesity. Definitely, the drugs are there, but what I would be essentially covering here is the topic of normal weight obesity and what research we have in India and in the Southeast Asian region regarding this topic, not only at a cross-sectional point of view, but over a span of a decade. So I thought I'll cover this topic very briefly in five domains that I would like to touch. I would begin with how we define normal weight obesity and what's the problem statement of this particular aspect of obesity globally as well as in India. We'll see what are the reasons behind this peculiar phenotype that we see in our country and in our region, our part of the world. But more importantly, for all of us as clinicians, why this is important. How does it affect our clinical practice? And what is the long-term impact of this particular phenotype? Follow-up data for 10 years from some of our work, but also global literature on this. And last but not the least, how do we manage this particular phenotype? So let's deep dive onto the topic right away, talking about the prevalence and the problem statement of obesity. And I think all of us here are well aware of problem of diabetes. And earlier this year, we know the 11th edition of the Diabetes Atlas was released at the IDF meeting in Bangkok. And we know our figures from India are just rising. But what has always been a very speculative figure in this particular atlas is the large proportion of people with undiagnosed diabetes in our country. And we see that this is not something which is only attributed to poor screening or poor understanding of the disease. Definitely things are improving, but possibly a contribution to this large proportion of undiagnosed diabetes is related to our phenotype, which is very well exemplified in this paper by Keefe et al., where they talk about a very high prevalence of diabetes in some of these countries. You see the South Asian countries standing out there, but paradoxically not so high prevalence of obesity. And we tend to have this particular paradox in this part of the world. A couple of years ago, we did a study in the community in and around Vellore, both urban and rural areas, in over 5,000 people. And what we were trying to see was what is the prevalence of new-onset diabetes, new-onset type 2 diabetes in individuals who have a BMI of 18.5 kilograms per meter square. And we were surprised that 1 out of 20 new-onset diabetes in the South Asian region, in Tamil Nadu, is having a BMI of less than 18.5. So there is definitely this paradox that still exists in our country, where we have people who have high-end metabolic problems without having a higher BMI. And this essentially questions as to how we actually diagnose obesity in our population. And for all of us, if we have to diagnose obesity and try and label people into different classes, I think there are two things that we try and look at. We try and look at an obesity indicator, and we try and see what should be the cutoff for that particular indicator. And, most commonly, we all would use BMI in our clinical practice, where if we look at the BMI and we know the cutoff, we would know whether the patient is normal weight, overweight, having obesity, or even sometimes morbid obesity. Over the years, a lot of work has been done to try and understand that BMI is possibly not the best obesity indicator for our population, and therefore people even with normal BMI tend to have high amount of body fat, the phenotype which is known as normal weight obesity. By definition, this phenotype would be anybody who's got a BMI which is in the non-obese range, a BMI of less than 25 kilograms per meter square, but a high body fat. So how common is this phenotype? We tried to answer this question in a cohort that we follow in Kerala, and what we found in this particular cohort with over 1,000 people, about 50% of the population was obese. The remaining 50% did not have obesity. but two-thirds of these people who did not have obesity actually had high amount of body fat, and that was one-third of the entire study population. So this was our data, but when we look at a meta-analysis which looks at data across the globe, we find that this phenotype in particular is very common in the South Asian region. In countries like China, India, and Korea, this has been more prominent than the Western world. Therefore, this has been endorsed by our national guidelines, both by the Endocrine Society of India and by the RSSDI, and even more recently by the most recent ESI guidelines that we published. So, friends, definitely the problem of normal weight obesity is common in our population, affecting about one-third of the normal general population. So why is it so common? Why is it more common in our population and not in the West? And if we were to cite the reasons, there are several reasons to highlight. And I think starting with the genetic predisposition itself, that highlights the first part of the answer. Again, a couple of years ago, we looked at this interesting study where we were looking at the visceral adipose tissue of postmenopausal mothers and their daughters who are married and settled elsewhere. So the environment now is different, but genes are common. And when we found, correlated their body fat, especially the visceral adipose tissue, that is something we found was very, very significant. Even people with normal BMI had very similar amount of fat between their mothers and daughters. And there's several genes which have been implicated in the prevalence of normal weight obesity. And this becomes even more relevant in our population where we do have significant amount of consanguinity, especially in the southern part of India. So I think the first part as to why we have more common normal weight obesity is the genetic reason. Apart from that, we also know something called as the fat overflow hypothesis, and this was very well shown by this study which was done by Dr. Salim Yusuf and Dr. Arya Sharma, which showed very clearly we as the South Asian phenotype have very limited capacity of subcutaneous fat. And the moment there is little extra fat, we tend to overflow this fat in the wrong area. So even in a patient with a normal or a small amount of BMI, with just a little extra fat, we have the fat in the exactly places where it should not be there, in the ectopic regions, in the visceral fat, and that is what is known as the fat overflow hypothesis. And I think that is the second important reason, genetically determined lower amount of subcutaneous fat is another reason why we have normal weight obesity. The third reason is again something to do with nutrition. We've got low birth weight and how low birth weight affects body fat, whole body of work done by Dr. Yagnik, and even data from Velo. We've looked at low birth weight, and we know that definitely low birth weight itself predisposes to development of higher amount of body fat later in the years, and this is further coupled with poor maternal nutrition, the thrifty phenotype per se, and even the environmental factors, especially migration of people from rural India to urban India has shown development of this phenotype of normal weight obesity. So friends, normal weight obesity is common. There are several hypotheses as to why this is really important from our perspective. But as clinicians, when we talk of normal weight obesity, it becomes a bit challenging because this is definitely an obscure phenotype. In the clinic, it's hard to convince my patient, look, your BMI is normal, but you may have high body fat. Physicians are not aware, the patients are not aware, and overall, the whole diagnostic criteria itself is not so much well established, and therefore there are a lot of clinical implications of this phenotype in practice. But what is the real importance to go after it if it is not so well determined? Well, when we look at Western literature, we realize that normal weight obesity is associated with significantly higher cardiovascular mortality in high income countries, in low and middle income countries as well. This phenotype has been shown to be of severe importance not only in elderly but also in young adults. When we looked at our own data and tried to look at the prevalence of diabetes, hypertension, and dyslipidemia in this cohort of normal weight obesity, we find it is significantly higher as compared to people who are non-obese, very, very similar to people who are having overt obesity. Another meta-analysis, this was published in 2022, again looking at the odds ratio of developing type 2 diabetes or hypertension or dyslipidemia, we see that the odds are very, very high. So definitely this particular phenotype has shown to have higher cardiovascular risk in patients who have this particular phenotype. So much so in the US now, even for military recruits, they are screening for this phenotype before they are included in the US Army. In the clinic, again, when we see patients who've got lean PCOS, I think it's just another form of normal weight obesity. And that is another phenotype that we see. Even during COVID, when we had so many patients who underwent different types of CT scans for their lung, when the fat was analyzed for these different patients and correlated with the severity of COVID, there was a direct correlation. So, yes, this presence of abnormal amount of high fat, despite a normal BMI, the phenotype called normal weight obesity, does have significant clinical relevance. But how does it really change when we follow up these patients for a period of 10 years? And this is a very recent paper we've been working up, currently under review at the Lancet Diabetes and Endocrinology journal. The questions that we really wanted to address were predominantly to try and understand what happens to individuals with normal weight obesity on long-term follow-up of over a decade, and whether these cardiometabolic disorders, the mortality, the heart failure, the admissions for cardiac events, is it more in this phenotype or not? And we used our data from the Kerala Diabetes Prevention Program. We got funding for this from the NHMRC to follow up at 10 years as to how this phenotype really changes. We presented this at the IDF meeting earlier this year. Very briefly, talking about the results at 10 years follow-up, we had about 87% people who were followed up over a period of 9 years, which is phenomenal for follow-up to have 87% follow-up. And if I was to just very briefly tell you about how these people changed over a period of a decade, we realized that people with normal weight obesity had significantly changed to the phenotype of overt obesity. Only 18% of them remained normal BMI. Rest everybody had changed over to obesity. But the bigger problem, not only the diabetes, hypertension, and dyslipidemia, but even the cardiovascular events, the hospitalizations, the mortality was higher in these individuals as compared to non-obese individuals. So friends, this is not a phenotype which is very benign, which can be brushed under the carpet. This is a phenotype, when we follow up these patients long-term, we find that their cardiovascular events and mortality, along with hospitalizations, are much more than people who are non-obese. And this takes me to the last part of my talk. So how do we address the issue? How do we manage these patients? And what do we have in terms of literature to treat these patients? And I think several guidelines have been written about how we manage patients with obesity. But then when specifically talk about the South Asian region, I think there is an correctly emphasized principle of giving higher amount of protein in our patients. However, in the small 12-week study, which was published in the British Journal of Nutrition, in people, in women specifically with normal weight obesity, they did not show that over a period of 12 weeks, giving high protein diet could make any difference. Nevertheless, this could make a change in people with overt obesity. When we looked at our own data, following a lifestyle intervention in people with normal weight obesity for a period of 2 years in a randomized controlled fashion, we found this phenotype showed very minimal change in their cholesterol and systolic blood pressure, but by and large, this phenotype is very, very resistant to change. Even at our 9-year follow-up, we find that there isn't much difference between the control and the intervention arm, clearly telling us that this phenotype possibly requires much more intervention. As Professor Donna Ryan was mentioning, that when we use these drugs, the newer anti-obesity drugs, and at this point there are trials which are running with these newer drugs in this phenotype of normal weight obesity, I think this is something which is very, very relevant to our Indian phenotype of obesity, and what these trials show in terms of reduction of fat, improvement of cardiovascular outcomes is something that is still to be answered. So friends, with this, I come to an end of my presentation. To conclude, definitely normal weight obesity is a common reality in our Indian population, seen in about 30% of our population. We looked at the different reasons why this phenotype exists in the South Asian region, whether it is low birth weight or the genetic predisposition, or talking about the fat overflow hypothesis. Several mechanisms have been described. When we look at the prevalence, yes, from a clinical standpoint, this is a phenotype which is associated with higher mortality not only in the developed world, but in the developed world as well. And is definitely the phenotype which has responded very poorly to lifestyle intervention in general, not only in the Indian subcontinent, but studies from globally as well. And we await what the impact of these newer anti-obesity medications would be on this particular phenotype. I'm aware of phase 2 trials which are currently running globally with semaglutide in this phenotype, and what the answers would reveal, only time would tell us. So friends, with this, I would stop here. Would be happy to take any questions.
Thank you, Nitin. Again, once again, it's a wonderful presentation and a topic which is very relevant to Indian setting. Uh, and the important thing that you talked about was the, fat spillover hypothesis, which is again very important to understand this phenotype. I don't know how far we are sure of this also happening, because this is one of the proposed things. We still don't know exactly why we are having this phenotype and what we can do. But certainly there was also at a point, a discussion about there was a paper about the lipostatic threshold of every individual. And beyond that threshold, again, you spill over fat and it becomes more of ectopic fat and visceral fat, which causes all the inflammation and comorbidities related to obesity. Now, you showed some very interesting data that whether you are doing exercise or whether you are going on high protein diet, it doesn't make much difference. So in these patients, uh, how do we go about reducing the risk for comorbidities?
So what we can say, thank you so much, sir, for that insightful brief summary and the question, which is very important, sir. From the current data, what I would say is, what we know is that at 2 years, it did not really help us in the 12-week study in BMJ that was published. It didn't show difference. Probably we need either a more long-term intervention or a more rigorous intervention. These
I think
interventions,
so. I
yeah.
think so.
So I think either of them would possibly answer, and the third way is going the way of drugs. But again, as Dr. Dona mentioned, giving these drugs at 27 BMI coming down to 18, we don't know what's happening, how much muscle is going down. But I think time will only answer what is the best way. But we're learning step by step as we do more research.
With drugs, the bigger problem is that people think that if you are taking drugs, they don't need to exercise.
That's
And
true.
protein supplementation is always a challenge in Indian setting where people are, pure vegetarian. Whatever you want to do, you can hardly make it to 1.5 gram of protein per kg, which is the recommended protein intake for these people. So that is always a challenge. And even if they are taking protein supplements, they are not exercising, so it is of no use. And this is where it's a big challenge putting these people on anti-obesity medications. So it's a very interesting area, and I think there's a lot of work required to be done in this area. Uh, do we have any questions in chat box,
Yeah.
Purvi?
Can you hear me? Good evening, everyone.
Yes, Dr. Sarita
Hi.
Bajaj,
Hello,
ma'am.
Bridge.
How are you?
Hello, Nitin. I'm very well, thank you.
Thank you,
So
ma'am.
I've enjoyed both the talks. I'm on the road. It's a very, very long drive, unfortunately. So I'm not switching on my video, but I've been there throughout. So Nitin, you just never cease to amaze me, and the work that you are doing is really admirable, and especially the follow-up. Like you said, almost 90% follow-up. It's really, really creditable. So congratulations. I really like the talk. But what I feel is that, of course, you said there's a genetic predisposition. So, which Dr. Yagnik has already been talking about for almost maybe 3 decades, right? He has a long follow up. But what would happen with the drugs that the molecules, the newer molecules that we are using for obesity? So, the anti obesity medication in individuals with the low body weight obesity. I think that part you didn't mention. You
Yes, ma'am. We still need to get the answers. There is a clinical trial which is running right now
Mm-hmm.
on people with normal weight obesity. But right now, another paper that I'm working on in the same data is with
Uh-huh.
respect to muscle mass and follow-up of 9 years.
Mm-hmm.
And these people with normal weight obesity have significantly lowered muscle mass. It is common sense that if you have a given body mass and if the fat is high, definitely something else has to be less, and that's low muscle here. And we know data from GLP-1 therapy that when somebody loses, say, about 10 kgs of weight, 70% of that is fat and 30% is muscle. Now, in these
Mm-hmm.
people with normal weight obesity who already have low muscle, that is my worry that, what our phase 2 trials with semaglutide will show us. We'll have these drugs in the market and, already have and cheaper drugs soon, and we will know what happens again in these people when we are using it real time here in India. But ma'am, that is only time to answer that question. We do not have data right now on drugs in this particular phenotype.
So there's one
And
question.
the long-term impact, cardiometabolic risk reduction at the end of the day will be a more important parameter, which I'm sure you're already looking into. Just not just the weight reduction, but how to translate into the cardiometabolic benefit, which is also, I think, these individuals are equally susceptible to those risks. Sorry, Purvi, sorry for that.
No, 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 go ahead, ma'am.
So again, some unanswered questions. Yeah. Am I audible?
Yes,
Yes,
ma'am.
ma'am.
Yes, ma'am.
Okay. Sorry. Go ahead, Purvi.
No, we just have a couple of questions in the chat box. And before that, I think I probably missed. But Dr. Nitin, how did you all screen these patients? Because they would not have sought help. It's still largely a a cosmetic problem in India, and or unless there's a metabolic manifestation, it's very difficult to screen such patients.
Right. So ours was a community-based study. So we randomized and did a randomized control trial based on blocks from the different villages, particular number of house numbers randomly selected. So this is purely a community-based study. We went to the community, not the patients came to us, and this is a community-based study. So
And any thoughts on how can we even raise awareness regarding this? Of course, this is a huge sort of awareness for physicians themselves, normal weight obesity, but how do we kind of raise this as a public health concern? How do we talk to the people about it?
right. So I think for clinicians, we do see this phenotype. In the OPD, sometimes we have a patient with lean NAFLD, somebody with a very bad, fibroscan value, and still having a BMI of just 23 and 24. And when we look at the other metabolic problems, they have quite a lot of them. Similarly, as I mentioned about the lean PCOS, young women who are thin but have, high androgen levels. We've ruled out everything of irregular menstrual cycles, they have pre-diabetes. So yes, I think we see it in the clinic. Sometimes we just don't understand why they have these metabolic parameters, but I think it is there, and it is just for us to recognize, maybe do more body compositions in our clinical practice, and then we will pick up this much better. So from the community perspective, again, the awareness is very important. I think bodies like AARO have to do this and take it up, spearhead how we have to bring this to the public as well.
Yeah. Hi, Nitin.
Yeah, ma'am.
A brilliant talk as usual. It was a delight to listen to the talk. I just had one question. I don't know if this makes sense, but does the Indian phenotype have more inflammation than our Caucasian counterparts? And can we measure it? One, in a study like your Kerala group. Second, can we do something specially about it to bring down the inflammation?
Yes, ma'am. So at this point, I don't have answers from this particular study, but yes, I think what can answer this is a huge biobank that we are generating from another cohort from Vellore. We just got large funding from Wellcome Trust to do that. And I think in time to come, we are going to run all the omics, the metabolomics, not only the known inflammatory markers, but probably several unknown ones as well, and see whether that will help us predict. But again, I think your point is very valid that there is going to be a lot more inflammation here, given that most of the pathogenesis of diabetic complications happens because of that. I think insulin resistance being core to this phenotype of normal weight obesity will have a lot more inflammation. But which is that
So,
parameter? Yeah, time will
yeah,
tell
yeah,
us.
Nitin, go. So, we did a small study couple of years back in the hospital when I was there. It's not couple of years back, I think 3, 4 years back. So, what we did was we screened all the people who were coming for the regular health check for their body mass index and waist circumference, and then we also screen them for presence of the components of metabolic syndrome. So normally when we say metabolically healthy person, we are defining that there are two or less components of metabolic syndrome. Now, in this population, we picked up people who had BMI less than 23 and not a single component of metabolic syndrome, right? And we measured their HSCRP, and they still had high CRP, HSCRP, which was twice, uh, 3 times higher than uh, the no, these are not low normal weight, these are obese, but uh, metabolically healthy. And we measured their inflammation by measuring HSCRP, and it was 3 times higher than the other population. So we are seeing high inflammation even in people who don't have any component of metabolic syndrome in Indian setting. But certainly we need large amount of data, larger studies which are more population based, and screen for something in terms of HSCRP, and even there are studies which have reported higher leukocyte counts in these people.
Yes, and I remember when I was working with Dr. Neeta, we also published two papers. One was with nitrotyrosine and the other with HSCRP. And
Little signal is, I think, gone.
Yeah, just
Signal, something wrong with the signal?
Yes, yes. Never
Yeah.
mind.
yeah, he's logged in again.
Good.
I,
Yeah, Nitin, your signals dropped, so you were answering
we
that.
couldn't hear you.
yeah. So what I was saying was when I was working with Dr. Neeta, we did publish two
Great
papers,
for
one with
teaching.
nitrotyrosine and HSCRP. Very similar findings to what you said, sir. And I think, as you rightly mentioned, larger community-based studies and biobanks need to answer this question better.
Absolutely.
And I was just, may I say something, Rich?
Yes, ma'am. Why not?
Like I think this comes out from what Purvi said, that how do we make a diagnosis and how do we know which people to screen. So I think Aero is planning some like train the trainers, like in specifically obesity management, because I think dedicated obesity clinics where the right knowledge is there, the right equipment, the right outlook, what needs to be measured, and which patient will be called normal weight or obese or overweight. All these things, I think the time has come for dedicated teaching in relation to obesity per se, and having clinics which are focusing only on this aspect, because that is going to be preventive. Primordial prevention will come from those clinics. If we are able to diagnose at the right time, pick up those cases, and then guide them from the very beginning.
Agreed, ma'am. So with that, I think we come to an end, Purvi, or do we have something else? So over to Purvi for the final comments and closure.
Sir, I'm just thrilled that we have so many members of our EC also joining in here, and it was an absolute delight to listen to Dr. Nitin Kapoor as well as Professor Dr. Donna Ryan. I think it was a very, very fruitful webinar, very good progress on discussions, and thank you for sharing all your insights. And very well moderated, sir, as always, Dr. Makkar, sir. So,
Thank you. I think we should, compliment Purvi for her persistence and her, zeal with which she passionately follows this activity and sets up
Absolutely.
everything so nicely.
Absolutely. Thank you very much, Purvi. I think you are the
Completely
pillar.
agree.
You are the pillar over here, major pillar. And it was wonderful to see everybody and to, of course, listen to Nitin and Donna.
but this
Thank
is
you.
a huge
Thank you.
shout out to the entire committee because everybody will have to partake even next time. We
Yes,
have something
yes,
coming
yes,
up soon,
yes.
and we need everybody to be here and to get charged for AOCO, so people don't forget. Do
No way.
register. It's going to be a fantastic conference, and this is just some preliminary sessions that we want to warm up with before you come down to New Delhi for the conference. So thank you again, everybody, for logging in, and we will be there soon with yet another interesting webinar.
Thank you.
Thank you, everyone, and good night.
Thank you. Good night. Good night.
Good night.
Should I end it?